Good evening. We're going to start our program. I am Fatima Malekian, professor, director of Southern University Institute for Food, Nutrition, and Wellness, and project director for Center of Excellence for Nutrition, Health, Wellness, and Quality of Life at Southern University Agricultural Research and Extension Center. In July of 2021, the United States Department of Agriculture's National Institute of Food and Agriculture, which stands for NEFA, awarded $1,768,000 grant to Southern University, North Carolina Agricultural and Technical State University, Tuskegee University, and the 1890 Foundation under the Center of Excellence to support the Triple Land Grant's mission of research, teaching, extension, to contribute solution to improve the health and well-being of underserved and minority population. Please visit our website at www.SUAC under Center of Excellence tab for more information. On behalf of our Chancellor Dean, Dr. Orlando McMeans, and the CEO team, Center of Excellence, I have the pleasure of welcoming you to part one of our webinar series focusing on nutrition, health, wellness, and quality of life. The webinar series actually is one of the programs under Center of Excellence. During the presentation, please, if you have any question, use our Q&A tab or chat box. The chat box, it says it's a little box that it says chat. You can just click on it and put your question in there. Your question will be answered at the end of the presentation. And now I'm going to turn it over to one of our wonderful students, Miss Naya Reese, to introduce our speaker for this evening. Miss Reese.
Hello, I'm sorry. Give me one.
If Miss Reese cannot do it, we don't want her to be in danger because I think she is driving. So I have the pleasure of introducing Dr. Andrews. How about that, Dr. Andrews? Dr. Ronald Andrews was born in Houston, Texas, and is an honored graduate of Hampton University. He obtained his medical degree from, forgive me if I say they pronounce it wrong, from Meharry Medical College in Nashville, Tennessee, and completed his residency in both internal medicine and pediatrics from LSU Health Sciences Center and Children's Hospital of New Orleans, Louisiana. Dr. Andrews is board certified in internal medicine by the American Board of Internal Medicine and has over 20 years practicing internal medicine and pediatrics in multiple inpatient and outpatient settings. In addition to his primary care medical practice, he was recently appointed as the Chief Medical Officer of Bring Back Louisiana by Governor John Bell Edwards in response to the global COVID-19 pandemic. He also serves as Medical Director of Relief Telemedicine, a virtual remote telehealth provider, and also actively provides medicated assistant treatment to or for opioid abuse patients in his community. Dr. Andrews is actively involved in his local community beyond the field of medicine and has served on numerous boards involving Louisiana Head Start program, healthcare centers in schools, Louisiana Medicaid Program Advisory Board, and the Louisiana Workforce Investment Board, most notably. Dr. Andrews is a member of Louisiana Medical Society, East Baton Rouge Medical Society, and Kappa Alpha Phi Fraternity Incorporated, where he currently serves as the community chair of Healthy Kappas, Health Communities, and the National COVID-19 Task Force. In his spare time, he enjoys spending time with his family, traveling, and is an avid golfer. It is my pleasure to introduce to you Dr. Andrews. So please let us give a warm welcome to Dr. Andrews. Thank you.
Thank
Dr.
you
Andrews.
Thank you so much, Fatima. I appreciate that. As we speak tonight, Fatima, if you will unmute for a second, is the floor just mine or
Yes.
the moderator? So the floor is just
Yes.
mine. All right. Well, thank you.
All the way until, just maybe we have to leave some time for question and answer, and I'm sure everybody is gonna have questions.
Okay. All right. Thank you so much for having me and the warm welcome I just received. I've looked forward to speaking with you this evening because the area with healthcare disparities and how they affect minority populations is so important. And it's a very large or vast topic, which we could address on so many different areas. Since we have a large audience and I'm not exactly sure how people look at healthcare disparities or what they know or aware are the ones that attract. So I'll try to limit my comments to those disparities that are most often tracked when we look at scholarly papers, and then tie in also with diet, exercise, lifestyle choices, and how they all intermingle with us and affect each other. So if we look at the 5 most tracked healthcare disparities, at least in America, number 1, and I'll define them for those who are not aware, it would be mortality. So mortality is pretty much equates to death. So how death rates apply to different race, ethnic groups, and then age populations, and those are usually tracked in the per 100,000 people in the population. So mortality obviously is the endpoint, unfortunately. So that is most notably tracked. Number 2 would be life expectancy. And I know a lot of people who have nothing to do with healthcare clearly know what life expectancy is. And that's just how long a particular person or a class of race of people will live over their life expectancy. And that's tracked obviously males, females, and then also by race. Burden of disease. Burden of disease is a nice lay term for medical healthcare people. We usually talk about morbidity. So a lot of times in doctors' conferences, we'll have what's called a morbidity and mortality conference. But morbidity is more like the burden of disease. So obviously having the disease, and then what are the negative untoward side effects from that disease? So that's obviously tracked, and it can be broken out into those same different demographic and age groups per 100,000 people. Mental health. Mental health has received a lot of attention as of late, surely as we've been in this pandemic. So mental health, looking at so many different areas that I'll touch on, not as directly associated with diet and exercise, definitely lifestyle choices, but 3 of the 5 measures that I'm gonna mention, diet definitely affects all of them. The next category that's usually tracked is insurance or lack thereof. So they look at whether you're insured or underinsured. So you can get into, surely in the post-Obama healthcare realm where people are mandated to have insurance. You have some instances where they may have insurance, but they may have a large deductible, or they have a policy where they qualify for federal IRS reasons without penalty to have insurance, but the actual coverage may be lacking. In addition to that, you may have people who obviously have federal or state funded plans, which may not cover exactly the same things that what they call a fully insured commercial plan. So those things are tracked per, the same categories and demographics. And then lastly would be the access of care. And so that's the closeness or nearness of care, whether that be in the inner city a rural area and compared to maybe a suburban area. So if we look at these things and how it applies to maybe the Southern University Ag Center and the grants that Dr. Fatima was mentioning, if you look at the three that I probably would spend the most time on would be the mortality, the life expectancy, and then the burden of disease. All of those things closely interplay with lifestyle, diet choices, and access to healthy food. So if we kind of go down, and I may go a little bit out of order, if I'd like to probably start it, to spend them with most of the time, though I hope not all, on burden of disease. So if I take each of the most common diseases that are tracked and show the worst impact on people of color, as opposed to Caucasian or non-Hispanic white, depending on how you classify them on a census form. If we look at burden of disease and we look at what, unfortunately, I told you they interplay, what affects mortality the most, those big ones are, and I'm gonna go through each of them separately, would be heart disease, diabetes, and cancer are the big three that I think we should spend the majority of our time on. So as a practicing physician, I see all three. If I went in order, and since we're coming to you live from Louisiana, let's start with diabetes. If you look at diabetes, unfortunately, there are some environmental as well as genetic components or causes of diabetes in America for sure, I'm sure internationally as well. But in Louisiana or in the United States of America, diabetes can be two parts, the genetic or environmental. And when we say environmental, we start talking about, it could be chemicals, don't get me wrong, air quality and the like, but obviously usually it's food choices and or exercise or the lack thereof. So if you look at all of the different measures that are tracked, diabetes being one of the top killers of people of color in the United States, we can look at some of the health choices that people make. Some of them, obviously, as adults may be their own, and some of them is just out of necessity. So if we look at diabetes, what you're dealing with is, and what will blow most people's mind, is that with diabetes, usually we start with, diet control, food control, and it's usually watching your carbohydrates are the main thing. And then from there, balancing out your proteins and everything else, and then obviously exercise and moving around. Well, if we start talking about impacts of diet on diabetes, we get into access for, I'd hate to say, it's honest to God truth, low cost, available good quality food. And so if we start talking about populations that, as far as housing is concerned, where a more minority area, then you start getting into food deserts is probably the first thing I would mention. And so if I have diabetes and I don't have a farmer's market, or I don't have a grocery store with good produce and good meat, lean meat choices, then all of a sudden my disease, which early on could be treated by just diet and exercise, then I'm at a disadvantage. And so what I oftentimes tell my patients is that surely anyone trying to live a healthy lifestyle, definitely if you have diabetes, you have to plan ahead and you have to plan your meals, accordingly. You can't wait until you're hungry or too late, because unfortunately what happens is by the time you're hungry, everybody knows the first and fastest thing available, surely if they have a drive-through, is a carbohydrate, laden meal. And carbohydrates wreak havoc on diabetes, worsen and progress the disease. You look at food deserts as the one example that I mentioned already, and when you're looking at these minority communities, it's oftentimes hard to find a full grocery store. So you do get times where you have churches, faith-based organizations, council on aging, some community centers where they will have a day where there's a farmer's market. There's some here in Baton Rouge. I know churches that have done it. I know out at the one of the community centers right there near Southern University, I just happened to be there one day, and a produce truck drove up, and it was mostly seniors, but I mean, they just swarmed this truck, blocked the driveway. But that was their one day, and for at least a couple of weeks that they had access to fresh produce. So I think that that's an important thing that needs to be available. So sometimes the location lends itself, unfortunately, to a food desert, and I completely understand capitalism. But the one tale I will share with you in regards to that is I originally, as Dr. Fatima mentioned, grew up in Houston, Texas. And the neighborhood I grew up in, it's a diverse community, mostly people of color. At least when I lived there, it's been gentrified to an extent now, but it was mostly an African-American community when I grew up there. But I mean, you could have, a family below the poverty lines, or, a family in the upper 10 percentile to 1 percentile of annual income, as reported by, the IRS, living within, less than a mile from each other. I almost say like it wasn't as much of checkerboard as we say in New Orleans, where you have $1 million mansion on the corner, and 2 blocks in, it would be, subsidized housing. But if I came to modern, when I grew up there, they had multiple grocery stores. Those grocery stores shuttered, no new ones came in. So then what happened is that people who know Texas, and this store may be available in other states, but H-E-B is a big Texas store. It's corporate headquarters in Texas. I'm going to say they opened up in my old neighborhood, was called the H-E-B Junior is what I'll call it. So it was just a small store. And this is probably in the late 90s, at the turn of the century, in 2000. So they opened up a small store, in essence, trying somewhat to give back. And it was a private, I won't say public-private, it may have been some public money, but, as far as tax rebates, so on and the like, that induced them to open a small, full-fledged grocery store in my old neighborhood. But what they found out, and this was in a food desert at that time, what they found out in short order, and I'm saying 2 or 3 years, is that when they looked at the price the revenue per square foot, which is how retail stores measure their success or failure as far as their bottom line, the per square foot, this store in this neighborhood that I'm speaking of, that's mostly minority, grossed higher than those that were in suburban areas. And if I'm not mistaken, at least in the Houston area, it was the highest grossing grocery store of that chain per square foot. So I'm going to say before year 5, they then built a full grocery store. So sometimes the misconception is that if you put all of these resources in, what's considered a minority area, what's considered a lower income area, is that the store was doomed to fail, or that they wouldn't have the support, or the population wouldn't have the resources. That's not always true. And then now, as this area is kind of turned over and gentrified, obviously they have more than one grocery store. After the success of this one, that grocery store expanded, and now all of a sudden, all the chains and Starbucks and everybody else, have come to the area down the street. So you have to have access to food, and proper food and nutrition is one thing, and it's the main thing. And definitely a food desert would definitely wreak havoc on one, since we're talking about diabetes, and diabetes being one of the leading causes of death in minorities. If we easily transition to the second disease, heart disease, that's usually tracked, I could start with hypertension. So hypertension, or high blood pressure, is a common name. Same thing. So much of hypertension is treated with, food and diet, and really limiting the amount of salt you eat. I don't know a particular heart disease that thrives in a elevated sodium or salt type diet. So low salt diet. Same thing, and don't get me wrong, I'm not knocking drive-throughs today, but there are not many drive-throughs where you're gonna find a nice, nutritious meal. The restaurant's goal is to sell as much food as they can, make it taste as good as it can, and usually that unfortunately ends up being either salt or fat, if not both. Those two components can wreak havoc on heart disease, which is one of the #1 killers usually in a minority population. So with heart disease and salt, starting with salt. Any quick food, unfortunately, usually it's going to be, laden in sodium, and those things can then raise your blood pressure, cause more significant heart disease, which would be like congestive heart failure. And then obviously it could lead to strokes too, with elevated blood pressure, prolonged elevated blood pressure, or an acute spike in blood pressure could lead to strokes. And all these things can be treated in addition to medication, but diet as a main component of it. So we obviously have to have healthy food sources and have availability for those things. And one of the sad things about everything I'm discussing is, unfortunately, if we're talking about marginalized communities, it's a thing that it seems like the less nutritious value of the food source, the cheaper it is. So if you're on a limited income, if you have government funded, food stamps or card, depending on the program in the state, and you want to buy in bulk, obviously the less nutritious food is going to be, go a longer, your money will go a longer way. So a lot of it is access, and then it's obviously planning, as I mentioned earlier. But food affects all these different things. If we go in addition to that, if we're talking about diabetes, then heart disease, the third thing that's usually tracked is cancer, so cancer deaths. So unfortunately, surely here in Baton Rouge in Louisiana, and even near Southern, we're near plants, so the air quality is not usually the greatest. But there's a strong link between obesity and cancers. So definitely when you're speaking of cancers and obesity, it's an issue of, a lot of times if you have more adipose or fat tissue, you have more estrogen. And so especially when you're dealing with female cancers, sometimes in men as well, the obesity lends itself to fueling the cancer once that the cancer is in your body. And this may not be detected until late, but the cancer would already be there, and obesity is a risk factor for that. If you start looking at why obesity is across all of these racial groups that we're discussing when we're talking about benchmarking versus minorities and disparities, obesity obviously exists in all populations, but it clearly is worse, a worse burden on people who end up having these diseases. So everything I've mentioned so far, from diabetes to different types of heart disease, cardiovascular disease, and strokes, obesity plays a role in worsening the burden of all of these diseases. So then you have the diet component of obesity, you have the exercise component, and some of it is genetics. And we're only continuing to understand obesity as a disease. And some of the problems with that is that, and many people don't know this, most insurance companies, and including Medicare and Medicaid, don't pay for or cover obesity-related services. So the problem with that is that if you go to your doctor, and even though these same entities, and most of these guidelines come from CMS, Center for Medicare, Medicaid Services, they know that obesity wreaks havoc on the body and can either start or worsen these disease processes, but they're not covered services. And I think, unfortunately, it's probably just a dollars and cents issue. So I think it's a monetary issue, but there's definitely more than a casual link between obesity and all of these problems that end up leading to a decreased life expectancy, increased burden of disease, and also a worsening outcome once you have, those said diseases. So I think that we have to look at those type of things to find a way to move the needle. And while we're talking about nutrition and those diseases, I'll say one of the failures in the educational process, and I'm not talking about the Ag Center, but when I was in medical school, I took both a nutrition class at Boston University, and this is in the 90s, in Boston University and at Meharry Medical College. And I'm gonna say universally, that's Tennessee and Massachusetts, universally around the country, and I pray that it has changed to date, is that nutrition was kind of considered the break or the easy class. And it just was not much weight to the nutrition class. And the one story I tell my patients to this day is that when I was at Boston University, there was a professor, and so in the 90s, he looked like he was probably upper 60s or 70s by then, but he was, a PhD, a doctor of, in the physiology department, and they had him teach the nutrition segment. And unfortunately, and this is the truth, as I'm telling it, is that he came into the class, and so what are we talking, 25 years ago, no more than 30, he came in and told us that vitamins, he tells all of his students, we were his students that year, that vitamins were a waste of time and a waste of money. And he told us that vitamins were liquid gold. And I remember it like it was yesterday, and his version of reasoning for saying it was liquid gold was that he was like, imagine once you take vitamins, and then when you go void or use the bathroom, urinate and use the bathroom, you'll notice that the urine color is a deep gold. So I call it liquid gold because while vitamins may mention it has 800% of that or 1,000% of that of the recommended daily allowance, he said your body can't absorb all those things. So I tell people, don't buy vitamins, they're wasting their money. Go eat a nutritious meal. Everything you need in the meal is already there. You're wasting your time and money, and it's liquid gold when you buy vitamins. And I know we weren't the first class that he taught, which is the only reason I referenced his age. And he was well tenured at the university. That was the only time I had heard that particular speech given or class in that way. But still, when I was at Meharry, the course wasn't given much more weight. And I'd really be interested to talk to some current medical students and see if those trends have changed. Because one of the things that wasn't on my bio directly is that here in Baton Rouge at Women's Hospital, I used to do all of the physical exams for patients receiving bariatric services. So weight loss services, fancy name for weight loss services. And I would do all of the physicals. So the patients who would come in and get the various procedures, usually that full gastric bypass, they had the lap band and the sleeve being the most common ones, and the sleeve is kind of the predominant one now. I would do physicals on them. Well, if they got the lap band, that was a quick procedure. They would go home the same day. If they had a full bypass or what they call a sleeve, they would stay in the hospital at least overnight, if not 2 or 3 days, and that's if they had no complications. I'm gonna say I had long found out that diet was a little more important than that professor at Boston University shared with us. And that medicine and that food really is medicine. And so in treating these patients and the number of patients that receive bariatric surgery here in Baton Rouge, it was probably I was probably doing physicals for about 9 physicians locally that do the surgeries. And this was all of their patients, at least that had them at Women's Hospital or a few of them at Baton Rouge General. I was even amazed as a doctor, as a practicing doctor. By then I'd been practicing at least 12, 13 years. Some of these patients who were obese and of different racial and ethnic backgrounds, some of these patients with the diseases I mentioned, not the cancer, but hypertension, heart disease, and diabetes, they would literally have their surgery, usually on a Monday. They would have their surgery. And obviously they had to fast before surgery. You have to slowly reintroduce food after their surgery. So, you might start with some ice chips, then broth, and work them up to at least a soft meal before they're discharged. I'm telling you that 90% of the patients who had bariatric surgery and had those underlying disease processes, they went home on no medicine. So if they came in on 1 or 2 blood pressure medicines, they came in on at least one, if not more, diabetes medicines. Oftentimes, more than not, they went home one day, this is 2 days without being able to eat whatever was the food of their choice, because we had a diet laid out for them so we could tell their progression before discharge. They went home on no medicine. And I'm sitting there saying that was an eye opener to me. Imagine you think, oh, well, somebody's diabetic and I have diabetes, I'm gonna be diabetic for the rest of my life, or I'm gonna have high blood pressure for the rest of my life. That, in fact, was not the case. And all of these people, if we start talking about body mass index, these people, usually to qualify for the surgery, had to have a body mass index, I'd probably say nearing, I think they could qualify at 32. Most of them were over 35, several, and probably the majority were probably close to 40, a 40 BMI or greater. And these people would go home on no medicine. So it actually would show you how the environmental impact, and I'm not talking about exercising, I'm talking about their dietary choices, over time, that led to the disease burden, but it went away in 1 day, if not 48 hours max. And I'm gonna say, as a doctor, I mean, my eyes were already open, but that then more than opened my eyes to the impact of what diet could do on a person's body and their disease process. So we have to look at, obviously, these are people who obviously, and some of them were people of color, but who had access, because they either paid for those procedures in cash, they paid for them in, if their insurance paid for it, or they took out, a loan, like Care Credit or one of those type of services. But they obviously still had to have the wherewithal. But I would just imagine what they could have had, had they made better choices previously, and not having gotten to that point, what the difference could be. But if we take the same people now, the disadvantaged population, or a minority population is disadvantaged, if they don't have that access, I'm not saying they should rush to go get the surgery, but if they don't have the money or the resources or the availability to get healthier food choices, then they don't have that option. And that's not something that's measured as a disadvantage, but you could just see the difference in those two things and how fast food choices can make a difference. And if I segment away from this, I'll lastly say that if you look at people with excessive BMIs that have decided to lose weight, and I sometimes will just say, just to give you an idea like that, show my 600-pound life. While I've never treated a patient at that extreme, we actually encourage patients who have some mobility issues because of their obesity to lose weight first by diet before they even ever attempt to exercise. And I often, not to discourage my patients from exercising, but maybe when they have excuses, they're making excuses, is I tell them, you could, if we did a study right now and I had one arm of the study, go to the gym 7 days a week, or at least 5 days out of 7, try to eat a healthy diet, and we put another subset of patients or another group just on diet, and we help coordinate their diet, they would lose more weight than the person, this has been proven, they would lose more weight than the person going to the gym every day or most days and saying, I'm eating a healthy diet. And obviously, sometimes you'll see just those who use physical trainers and everything, is more than just come exercise at the gym. They want to have meal prep and plan, because diet is that important. And I can only hope, as a practicing medical doctor, and I think I'm going to ask for myself, if medical schools are doing a better job than they were, 30 years ago, because I think that was a complete failure. And if I didn't have one-on-one experience, I didn't come out jaded that I wouldn't tell my patients to buy multivitamins because they were a waste of money. But I still tell them that I would go buy the cheapest multivitamin, eating a healthier diet, and buy the cheapest multivitamin that they could find, even if it's the dollar store. I do think that there obviously is the benefit. It's clearly a billion-dollar business. But in addition to that, I think some of what the professor was saying kind of flies in the face of, unfortunately, the disadvantage is that everybody doesn't have the opportunity, be it resources or access, to eat a healthy diet all the time and have the money for 3 square meals a day. So it's easy to say, just eat a better diet. You don't need vitamins. It's always not, unfortunately, it's not always just that simple. So I think that is some of the major things of how diet can mainly affect, surely when we're talking about, morbidity or the burden of disease, mortality, and the life expectancy, and then obviously the access to those types of foods and food choices. So I think we have to have a plan where we can, improve those things. And when we get to questions and answers, I see some of those types of comments are popping up on my screen and in the chats. We can get to them. Some of these things obviously is government funding problems. Some of it's private, as I talked about the grocery store. But we have to find a way to get it, a place where everybody has an even footing, so that we can move the needle, because we're at an impasse right now. One of the first times where actually life expectancy is going backwards. And especially that's in African Americans, and more specifically African American males, where the life expectancy is actually decreasing and not stable or increasing as they look at it over a time span. I would say if we touch some of the other areas, and this kind of goes to some of the questions that have popped up, but I won't answer them directly. Same thing if we're looking at the other health disparities that are oftentimes mentioned. Number one, the one I mentioned earlier, but we didn't talk about because diet doesn't impact it. But insurance, or the lack of insurance, health insurance, or underinsured, definitely impacts, obviously, your access to a doctor, your access to proper medications. Surely you get into, and we know what insurance costs today, even if it's somewhat subsidized by your employer, obviously it's still a significant expense. And it definitely plays into your overall health, just by be it access to the appropriate doctors and appropriate referrals, so on and so forth. I mean, there are definitely specialists here in our area who don't accept Medicaid referrals. So those same people who we may be talking about are in some of these impoverished areas. If they qualify for Medicaid, then they obviously can't always get to the doctors, of their choice, or a doctor of need or requirement. So I think that's, another thing that needs to be looked at. Since we're talking agricultural center, and I'll talk a little bit about trees. And this is new to me. I not for this talk in particular, but probably about a month or two ago, a colleague of mine brought it up to me, a friend and colleague. We were talking about, global warming, the storms that are worse. We just experienced a hurricane here, and we were talking about the heat waves. And there was actually there's actually studies in Spelman College is one of the lead investigators on basically where trees are planted in cities. So this is a kind of a government thing, where trees are planted in cities, and they could look at in minority areas or areas that were, redlined years ago, even though some of those practices are still happening today, that there were less trees planted in those areas. So then there was less tree shade, more, more asphalt or concrete, and less green space. And they looked at in the Atlanta area, where an urban area, as opposed to a suburban area, as wooded as Atlanta is, that the degree difference was sometimes as much as 5 to 7 degrees. And what ended up happening is those people in those lower income areas where there was less green space end up suffering from more heat waves and heat strokes and the complications of heat, as far as death, dying, unfortunately, but kidney failure, worsening of their diabetes, worsening of their blood pressure, because of just the heat. And then the concrete and asphalt absorb the heat and the rays from the sun during the day, and then it was even warmer still at night. And you can often look at, the biggest contrast area, if I mention that, if you look up, and I looked up specifically for this talk, but I had experienced it myself once when I was visiting in Los Angeles, California. The people watching the news, reading the newspaper, and just watching the trends, if you looked at and all of y'all can verify this probably on your weather app right now, if you look at Los Angeles downtown, but then you look at Santa Barbara, which from some parts of Los Angeles is less than 15 minutes away, that degree difference can sometimes be 5 degrees or more. And then if you're talking about a fragile population, that becomes a big issue. And I'll say lastly, so I'll make sure it leaves at least 15 minutes or so for questions. Same thing that here in Baton Rouge, so what I did do for this talk is I looked up what's considered Baton Rouge, so inner city Baton Rouge, and compared it to Prairieville and then Zachary, for those who know the area. And believe it or not, it was a 2-degree difference just between those areas. And these are areas we can traverse in less than 10 to 15 minutes, without traffic. And so obviously heat plays, a role. Usually it ends up being dehydration first, but then those untoward effects that follow are dependent on your disease state. So I think in summation, and then we can go to questions, is that based off of obviously this talk and it's Southern University Agricultural Center, the impacts of diet definitely have a significant role on 3 of the 5 measures of health disparities that are tracked on a usual or frequent basis. And unfortunately, minority populations are disproportionately affected by it. So I think we have to do better. Some of the questions I'll save comment for the questions that were asked, but we have to do better with food choices, and the nutritional value of those foods if we want to impact those things in our communities. Thank you. Dr. Fatima, if you would like to say, I can see some of the chats. I don't know if you've written down and want to call out to me which ones you want to answer.
Dr. Andrews, Brittany is going to come on and ask you those questions.
Okay, perfect. Thank you. Hello, Brittany.
Hello, how are you? And hello, everybody. And thank you all for coming. And thank you for being here, Dr. Andrews. And so I will get started going through some of the questions. So the first question is, what are common signs of heart disease?
Heart disease can sneak up on you. So doctors saying it was pretty popular maybe about 10 years ago is a big thing, and it's still true, of knowing your numbers. So it can be silent, unfortunately, early. So you need to make sure you see your doctor and know what your numbers are. If I had to say symptoms to answer the question, number one, some people might notice would be a rapid heart rate. They might what they call, tachycardia, rapid heart rate, or palpitations. That could be a sign of heart disease. Sometimes frequent headaches for no reason. Maybe a sign that you have elevated blood pressure, but you've been previously undiagnosed. And obviously you have that, you can buy a home blood pressure monitor, but obviously if elevated, or make sure it's accurate, check with your doctor. The heart disease that most people think about, and I didn't really mention more, is like coronary artery disease. I didn't mention, and sometimes unfortunately like cholesterol or fatty foods add to that plaque buildup in the heart. So that's when people get that commonly known, oh, I have chest pain. The chest pain from heart disease is usually, chest pain that it can be with exertion or at rest, and it lasts at least 20 or 30 minutes. Usually 20 minutes is the timeline. So those are the big things. So I'd say some funny heart, like my heart is beating right now. Brittany, everybody obviously listen, heart is beating, but I don't feel it beating. I don't have what we call heart awareness. So if you feeling some funny beats or double beats, or you're aware that your heart is beating, and I'm not saying sometimes in the still of the night, you can hear it in your ear, depending on your position, but I'm saying you can feel some funny heartbeats, obviously frequent headaches that are new to you. And then I'd say that chest pain is what most people think about with heart disease. And lastly, sometimes like shortness of breath, unexplained shortness of breath with exertion, or shortness of breath when you lay down at night or recline too much in a recliner. All of those can be some subtle signs that may lead that you might have some underlying heart.
Thank you for that. Okay. So our next question is, around Southern University has been considered as a food desert. How do you think we can reverse this situation?
You know, I think some of it is some of the things I mentioned, and I know it's going to take a public-private venture in this, and that could just be some tax incentives. Don't get me wrong, and it's the sad thing that that is the case. That that area is, and it was at the I think it's called the Charles Kelly Community Center. That's right off of Plank, Scenic and Plank area, where I happened to be there, and they had the fruit truck, the produce truck that came, and I mean people swarmed that truck. I had to back up out of the driveway because you could not get through the usual way to get to the parking lot. But I think it's going to take a public-private measure. And I know people have looked at it and people have been working on it in the development office. And I know they're revitalizing Plank Road right now. I know that's a big deal. And I've heard some great things about how it's coming along. But I think it's going to unfortunately have to be some tax incentives to get, a grocery store, whether that be a mom and pop grocery store or a big chain, to take a chance, and hopefully that would turn out to be just like the example I gave in Houston, where I grew up. There's nothing definitely, different about that neighborhood. Texas Southern is nearby, but it's going to take something like that. And then we all know that there are people, not just in addition to the Southern University students, there's a large enough population that could support, a store in that area. But I think it's going to have to be the right combination of a private companies willing to, risk some of the resources, and then obviously public, probably with some tax rebates, and then for us to support the store as well.
Okay, so we have time for a few more questions. So the next question is, if I come from a family that has a history of heart disease, what can I do to help break the cycle? And then a follow-up question to that was, what is a true healthy BP? So what is a true healthy blood pressure?
So I'll start, that's the easy one. So doctors, we like to say anything 120, the top number is systolic number 120, and the bottom number is diastolic number 80. So anything equal or under to 120 over 80 is considered normal, a normal perfect blood pressure. If you start looking really deep into scholarly articles about blood pressure, and I've often kind of backed away or balked at some of these because they are aggressive. I mean, there are studies that show, honestly, while 120 over 80 is the gold standard of blood pressure in the textbook, that really the lower someone could have their blood pressure and tolerate it, and what we mean by tolerate is that you're not about to pass out, that you're not going to faint or feel really woozy, dizzy, or tired just trying to ambulate around, much less exercise. But there have been studies that people whose blood pressure either naturally or with medication are really down to 90 at the top number, 60 at the bottom, actually, do better and have a better electrical system. The lower the pressure, the less it has to work to pump the blood around your body. So the lower the number is, the less wear and tear, if you almost relate it to like, something in a motor or in your engine in your car, the less wear and tear, the easier it is and the longer it will survive. So 120 over 80, but obviously we shoot for a little bit lower. If you have known heart disease in your family, was the second part of that question. I'd say the main thing would be diet and to see your doctor and get checked up, but diet and exercise. I mean, we know if we're eating a low fat, low cholesterol, low salt diet, and I'm not saying you can't ever have any food that maybe tastes a little bit better than what that sounds like. But that would be the main thing, is doing those things that are heart healthy. And so a lower salt diet, I mentioned earlier, would be heart healthy, a low cholesterol, low fat diet, so you don't build up that plaque and atherosclerosis in your heart and in your valves and and along your arteries around your heart that lead to heart attacks or valvular heart disease. Those are the things that will be important that you can do. And I always tell my patients, you can't escape your genetics. Your parents are your parents, your grandparents are your grandparents, but you can do your part. And while you might not be able to, cure the disease if it's genetic based, you can surely lessen or mitigate some of the, morbidity or burden of disease, which is one of these healthcare disparities that we spoke on tonight.
Okay, I think we have time for 2 more questions before we give the closing remarks. So the next question is, how true is it that diet alone without exercise can help reduce weight? And is there research done to prove that?
Could you read that beginning? How long? What did you say?
How true is it that diet alone without exercise can help reduce weight? Is there research done to prove that?
Yeah. So Brittany, I mentioned that earlier, so I don't know if that question came in before I actually said that exact statement, which is fine because it's worth, going over again. In that, in any patient, but surely in extremely obese patients, most of those articles, scholarly articles, are in extremely obese patients. And again, like I told you, you could take 2 groups of people. In one arm, you put them in exercise. We'd hope diet and exercise. But even if it was diet, eat better and exercise as many days as you can. Let's say at least 5 out of 7, just to say it. Or we told somebody, we're going to prepare your diet for you and you're only going to eat those things on this diet. I promise you there are articles that are proven. You will really, diet is how you lose weight. Exercise is how you maintain it. Point blank. That is known all throughout the medical community. Diet helps you lose weight. Exercise makes you maintain it. If I added something, not just with weight loss, but that would obviously help with blood pressure, but diabetes. When I was a medical resident at LSU at Children's Hospital, I actually received the pediatric resident researcher of the year award because we had a program with some adolescents that had what they call maturity onset diabetes of youth. So usually these are obese children who develop adult type 2 diabetes because of their diet and exercise choices. These patients on this diet, number one, they did lose weight, and that was important to them. That was kind of the buy-in for them that they lost weight as a child, as a teenager. It eliminated their diabetes. Just the same way that I told you these bariatric patients after surgery have, 48 hours after surgery, they don't need blood pressure, diabetes medicine. We took the same thing, and I presented this paper nationally. We did the same thing in adolescents and teens, and they were able to, by laboratory data, prove that their diabetes was completely under control without medication, just on diet. And they did not have to exercise. It was encouraged, but exercise was not a component of it. Unfortunately, what I was explaining to a patient this week in the office is that while that's great, and this was on Monday, while that's great, he was a pastor. So I told him, if he backslides or, he falls off the wagon, that the disease will come back. It's at bay, it's not cured and gone, but it's so much under control that it's not detectable. But that if he began to gain the weight again and eat those things he shouldn't eat, that the disease would come back, in the same, vigor that it originally, was.
Yes, sir. Thank you for re-answering that question. And I believe that's all the time we have right now for questions and answers. So if Dr. Marshall would like to come in and say some closing remarks. Thank you.
Hello, everyone, and thank you all again for joining. Thank you so much, Dr. Andrews. I must say that Dr. Andrews is the best physician on this side of the planet. And Dr. Fatima is going to give some closing remarks, but I did want to publicly say thank you so much, Dr. Andrews, for joining us for our first part series of our webinar. Thank you.
Thank you for having me.
And I want to personally thank you as well, Dr. Andrews. Also, before we finish, I want to acknowledge the wonderful team that we have in the Center of Excellence. And first and most, my chancellor, Dr. Orlando McMeans, that has been a great support for this, establishing this center, and from Southern University, Dr. Marshall, Dr. York, Miss Brittany Howard, from North Carolina, Dr. Parker, Dr. Sang, Dr. Alexandra, and from Tuskegee University, Dr. Dawkins, and from 1890 Foundation, Dr. McLaurin and Dr. Neville. Thank you all very much for participating, and Dr. Andrews, thank you again. And hopefully we start working together, because a lot of things that you talked about is what is our plan to do in the future to make a better life and enhance the quality of life for our people and population. Thank you, and have a wonderful evening.